What's up, FRT community? So we've got a topic here for you today that I thought I had covered before, but apparently I haven't. I got an email from Todd who said, hey man, I'm looking through your channel. I don't find anything on waveforms and loops. Can you break that down? I said, yeah. I thought I had a video on it, but obviously I didn't. And so we're going to do it now. Okay. So if you've been looking for something on waveforms and loops, and I'm glad you're here today. If you haven't already, hit that subscribe button. If you like this video at the end of it, give me a thumbs up. I'd appreciate it. And if you have any questions or comments or concerns after this video, put them in the comments and I'm going to address them. Okay? So what we're talking about are waveforms and loops. And before we get into actually breaking down the waveforms and loops, what I want to do is tell you that waveforms and loops is one aspect of respiratory therapy that separates the superior respiratory therapist from the average respiratory therapist. If you're going in and you're writing down numbers and you're not assessing your waveforms and your loops, then guess what? You're an average respiratory therapist. Now you can change that. You just got to start looking at this stuff. But to look at it, you have to understand what it's telling you about your patient. Because you see, when you're just writing down numbers, and if you don't even have your waveforms pulled up on your screen, if you've got, I know there's some vents out there where you can just put monitors up there and it'll just give you numbers. You're missing so much about your patient, and I hope this video illustrates what you're missing about your patient. Okay, so here we go. On the board here, I have our pressure waveform, our flow, and our volume waveform. Now, these are the three standard waveforms. Now, the pressure waveform, obviously here, has an inspiratory hold that's illustrating plateau pressure. I'm just going to break it down and show you what you can find on your pressure waveform and what it's telling you. We know that if the peak here is PIP, and then this hold right here gives us plateau, and then we return to PEEP. Now, after we return to PEEP, we can assess mean airway pressure by looking at the amount of space beneath the waveform. It's an average of all the pressures throughout all the breaths. So if you spend more time at PEEP because you have a slow respiratory rate and you're at PEEP a lot, then obviously you're going to have a lower mean airway pressure. Now, if we increase the PEEP, then obviously mean airway pressure is going to increase. And everybody understands that the two ways we can increase PaO2 is by increasing FiO2 or increasing PEEP. But what we fail to understand sometimes is that when we increase PEEP, what's really happening is that we're increasing mean airway pressure. And mean airway pressure is what actually works to recruit atelectatic alveoli, increase FRC, and improve oxygenation. It actually gains more functional alveoli. That's what FRC is, functional residual capacity. And so when you understand those concepts, you're in a good place to understand where you are. Now, we also might see here a dip just prior to the breath. That is telling you that it was a patient-triggered breath if you're in pressure triggering. Now, if you're in flow triggering, you may not see this dip. But if you're in pressure triggering, which is harder than flow triggering, then that dip right there tells you that the patient has initiated a breath. Now, before I get into the rest of them, let's talk about this. If you have a dip and no breath that follows that dip, then guess what? Your ventilator didn't respond to your patient's inspiratory efforts. Therefore, it failed to give a breath even though the patient was asking for one, which sounds like torture, right? Like if I want a breath, I should be able to get one. Whether it's a true spontaneous or if I'm getting whatever the machine is set in AC. Doesn't matter. If I want a breath as a patient, sounds like torture if I ask for one and don't get it, right? So look at your sensitivity if you ever see a dip in the pressure waveform that isn't immediately followed by a breath being allowed, okay? I'm going to erase this because I'm going to need this space here in just a little bit. Okay, when we look at our flow, we're in volume control here. This is how we know our pressure waveform is slowly rising and then peaks up here at peak inspiratory pressure. So when we're in volume control, we know that we set a peak flow. Okay? Now, some of you are going to say, well, I don't set a peak flow. My vent sets an I time. Look, it doesn't matter if you set flow or if you set I time, what you're telling the ventilator to do is if you set flow and you have a set tidal volume, then your I time is going to be fixed. If you tell the vent to give a set I time and you have a set tidal volume, then your flow must be fixed to give that tidal volume over that inspiratory time. So either way, your flow pattern is going to be fixed. And what we're looking for here is a rise and then a decelerating waveform that comes back to zero, and then expiratory on the bottom. This is the key. Inspiratory on top, expiratory on bottom. Okay? When you're looking at this, normal, and you have to understand normal to recognize abnormal. Then you understand that normal is that on the expiratory side, it returns to zero. It returns back to baseline. That means that before the next breath is given, your patient's expiratory flow back to the ventilator has ceased. It's come back to zero. And that's a good thing. Okay, we're going to talk about what happens when that doesn't happen here in just a second. Now your volume should start at zero. If you have, let's just say you have a tidal volume of 450 set, then this should rise to 450 and fall back to zero, which means that 450 goes in and 450 comes out. And that's normal. Okay, so now let's break it down and look at some abnormal findings. Okay, so as I get into this, I want you to understand that all of these are going to be abnormal, but they're not all abnormal at the same time. Okay, so we're just talking about pressure waveform and some abnormalities you might find on a pressure waveform. Now, I already mentioned one. That is if the vent fails to recognize a patient effort, where you might see a dip in your pressure waveform, but no breath given. Other than that, you may see this rise and then dip down, and then come back up and then exhale. This dip is telling you that your patient is flow hungry. Okay, so this dip is flow hunger. Excuse me. When you see this, you have to understand that what's happening is because your flow is set and because your volume is set, the only thing that can vary when you're in volume control is your pressure. So you go, well, this is weird. My flow looks normal and my tidal volume looks normal, but I got this dip in my pressure waveform. Well, that dip is telling you that the patient's inspiratory demand, what they're asking for, is a flow greater than what you're giving them. So the flow starts, and this can happen throughout the entire phase. It can be early, or it can be late, or it can be right in the middle. So you just have to look at it and ask yourself. But what's happening is the diaphragm is dropping faster than what the vent is delivering the breath. And this is flow hunger. Okay, now I'll be honest with you. We had a patient the other day who had something like this, and their diaphragm is dropping faster than what the breath is given, and then their diaphragm comes back up, and you get this sharp rise in peak inspiratory pressure on your pressure waveform. So you have to say, okay, we're trying to give this breath at 45 liters per minute. But the patient wants more than that, so let's increase our flow. Now, what's crazy about this is that here, our peak inspiratory pressures were happening like at 20 centimeters of water pressure. They weren't bad, but they were 20 centimeters of water pressure. We ended up increasing this patient's inspiratory flow all the way up to 95. Now, that's 95 liters per minute. I know that sounds crazy, but hear me out. At 95 liters per minute, inspiratory flow, what we found is that our peak inspiratory pressures actually went down to 18 centimeters of water pressure. Now, you typically think, well, if I increase flow, I'll increase pressure. But that's not the case when you're dealing with a patient who's flow hungry, because you had an asynchronous situation here. So the diaphragm is trying to come back up while the vent is still trying to give a breath, and you get a sharp rise in your pressure waveform. And so when you catch up to that patient's inspiratory flow, the inspiratory flow that the patient is asking for, not what you're given, but what you're asking for, then what you'll do is find that your peak inspiratory pressures won't really increase that much. Now, if you have a patient not breathing at all, and their diaphragms are still, they're not breathing at all, and you take somebody's flow up from 45 to 95, of course their peak inspiratory pressures are going to go probably extremely high. So I'm not recommending that. What I'm telling you is that when you find somebody flow hungry and you see this, then you need to give them more flow. And you will find that through increasing your flow, you don't get a rise in your peak inspiratory pressure. You're actually going to get things to settle down. And what happened with this patient for us is that their rate went from 35 down to 24. Why? Because we were satisfying their need to breathe. We were making the ventilator breathe like what they were asking for. And that's the key to all of this, okay? Now, when we go down here to flow, separate from the flow hunger issue, okay? This is another one. When you're looking at flow, so this is example 1. Now, example 2 is if you ever see this. Your flow comes like this and like this. Now, the problem here is this gap between baseline, okay? So if your baseline, if your flow fails to come back to baseline, then you have a patient who is air trapping. This is air trapping. Okay? Now for this patient, even though they may not appear flow hungry, they may still need their flow increased. Now the reason you would increase this person's flow is to decrease their I time and give them a longer E time before that next breath comes. And you can do this various ways. You can do it through increasing the flow. That'll decrease your I time and increase your E time. You can decrease the tidal volume. That'll decrease your I time and increase your E time. You can decrease the respiratory rate. Decreasing the respiratory rate does nothing to I time, but it increases your total cycle time, which increases your E time. Now, we typically don't go to decreasing tidal volume or decreasing rate because those two alter your minute ventilation. And if you alter minute ventilation, then you alter CO2 removal and you alter pH. So that's why increasing flow here is typically where we want to start to try to get that I time down and give a longer E time. Now, the other thing you can do here when you have a patient air trapping, it depends on why they're air trapping, is increase PEEP. Increasing PEEP allows those airways to be stented open, specifically in your emphysematic patients. They have airway collapse and distal airway collapse, and a lot of air is trapped in those distal airways. And so if we can stent those airways open and prevent the collapse, then we can allow for more complete exhalation before the next breath. Okay? So just a few ways to fix air trapping. Now, when we look at the volume, this is example number 3. Volume comes up and it doesn't return to baseline. Now we have a problem down here. Okay? So this is dependent on a couple of things. What's the problem? Well, there's one of two problems that's happening. You either are air trapping or you have a leak. Okay? Now, here's how you tell the difference. Look back at your flow waveform. If it doesn't return to baseline, then this isn't coming to baseline because your patient is air trapping. But if you look back at your flow waveform and you see this, then this is a result of a leak. Okay? So you have to be able to kind of critically think about this and go, okay, volume's not coming back to baseline. That doesn't tell you anything. You have to look back at your flow waveform to assess exactly what's happening. Okay? Now, I have to erase this to give you this fourth one, and then we're going to go to our loops. Okay? So I'm going to erase all of this. I'm going to come here, erase this. This is our fourth example, and I need all 4 of them to show you. So you get a breath, maybe a slight dip, and then another sharp increase in a breath like this. You come here, you get a breath, and then another breath like this. Okay? Now, when you look at your volume, you get a volume up, and then it immediately starts back. It comes back, and then it immediately starts back here and comes back like this. Now what's happening here is that your patient is breath stacking. They got their first breath, but at the point of exhalation, they initially triggered another one. This is typically because your tidal volume is not large enough for this patient. Let's say you have them on a tidal volume of 450, okay? And you give that 450, but let's just say the patient wants 470. Well, then obviously 450 is not going to meet it, right? Their drive to breathe is saying, I want more volume. So their diaphragm continues to drop throughout the breath, and as soon as the breath is delivered, the vent cuts off, yet it delivers and is triggered another breath immediately. And you see something like this. This is breath stacking. Now, when I showed you this, I should have come way down here below. And what this is saying is that the first breath went in, a little bit came out, but then another breath was given, and all of this breath plus all of this breath is going to come out. The first 500 goes back to baseline. The second 500 comes out below baseline. What you've done here is essentially given the patient 1,000 ml. What would we say? We're on 450? So if you're on 450 and you give 2 back-to-back breaths, you've basically given the patient a 900 ml breath. You didn't give it. They asked for another one, and they got 900 mLs. That's a problem. You don't want. We went to low volume ventilation, or what I would argue is normal volume ventilation, to get away from the barotrauma associated with large tidal volumes. So if you have a patient breath stacking, you have got to get that fixed. Ask yourself, can I stop this if I just increase my tidal volume just a little bit? You're probably stuck on 6 mLs per kilo. But remember, we can go up to 8 mLs per kilo. So 450 may not be, if that's 6 mLs per kilo, if let's just say 480 was 7 mLs per kilo, and at 480 you eliminated this, then guess what? You've satisfied your patient's drive to breathe for what they're asking for and what they want. Your patient wants a little larger tidal volume. Is it more dangerous to give 900 mLs routinely through breath stacking? Or would it be better to give your patient, instead of 450, give them 480? It makes sense to me, 480, if that meets the patient's needs and eliminates the breath stacking, that might be the way to go, right? So be aware of that, okay? Now from there, we're going to break down the loops. So I'm going to erase all this. And we have 2 loops. We have the flow volume loop, flow volume loop. So the flow volume loop looks something like this. This is normal, okay? Volume goes in, flow and volume goes in, and then flow and volume is exhaled. Okay, so the top is inspiratory, the bottom is expiratory. Now you have to be careful with this, because when you get into PFTs, it looks more like this. Okay, but it's the same thing. It's telling you the same thing about your patient. Okay. Now, when this is what normal looks like. So here's some abnormal findings. If you have this, then this is a sawtooth pattern, and that sawtooth pattern is telling you one of 2 things. Either your patient has excessive secretions, or your patient has water in the tubing, or this is a result of turbulent flow from bronchospasm. But most commonly, your patient either needs to be suctioned, or you have condensation in your circuit that you need to drain. You need to get it out because it's disrupting the flow as it returns to the vent. You can also have this on the inspiratory limb. Now what's nice about this is if you have one or the other, let's say you have this right here, then I can almost guarantee you know exactly where the condensation is. It's on the inspiratory limb of your vent circuit. Why? Because the sawtooth pattern is happening on inspiration. This is exhalation. Okay? So you can kind of use this to say, okay, my patient's breath sounds are clear, but I've got this sawtooth pattern on the inspiratory limb. Let me check my inspiratory limb of my circuit. And not guarantee, but most likely you're going to find excessive amounts of condensation in that inspiratory limb. Okay? Now, from here, it brings us to this. This is normal. If you ever have this, that's obviously abnormal. Now, what I call this is the scoop in your loop. Okay, so if you have a scoop in your loop, what it's telling you is that your patient has some sort of obstruction. Now, what you have to do is figure out what's causing the obstruction. This could be anything from secretions, bronchospasm, the disease process associated with emphysema, which is an obstructive lung disease, or any of the CBABs. Your patient may even be biting the endotracheal tube. All of those things will cause an obstruction to expiratory flow. You need to figure it out and address it. If it's secretions, suction them. If it's bronchospasm, give them a bronchodilator. If it's emphysema, you really can't do anything about it. It's the disease process. If the patient's biting on the endotracheal tube, maybe you need to consider putting in a bite block or increasing sedation. So there's that, okay? Now, from here, we go to my favorite loop. And this is the pressure volume loop. Okay, now the pressure volume loop looks something like this. You're starting at a PEEP of 5. You get a breath in and you get a breath out. Something like that. Okay? Now, there's 6 talking points that I like to talk about when it comes to the pressure volume loop. Okay? So we know what normal looks like. This is what it looks like. Now I'm going to show you abnormal. So I'm going to come way back here and then start my breath. Okay, so this is obviously abnormal, right? Here's the 6 talking points. Number 1, if you see a fishtail, something like this, then it could be an indication of your patient having an increased work of breathing or struggling to trigger the vent. Okay? That's what the fishtail tells you. Okay, so this is the fishtail. You need to assess your sensitivity and you need to assess if your patient is flow hungry or not, because those things will impose and cause your patient to have an increased work of breathing. Okay, now as we move around, we get over here to this point, and this is point number 2, and this is critical opening pressure, okay, or critical opening point. This is the point at which the alveoli are now open and are going to easily accept volume. If you look at this, you realize that the first part of this, there's a high level of pressure, but not very much volume. Volume goes here. This is volume. Pressure is along the x-axis. So anytime it's moving lateral and not up, then you have an increase in pressure without very much volume change. So at this point, you can see, I'm going up now, right? This means the alveoli have popped open and they are ready to receive volume with very little pressure change from this point, okay? And this is also referred to as the lower inflection point. I like to say don't give the cop lip. So you put those 2 things together. Critical opening point goes with lower inflection point. And what this will tell you is ideally in theory, if we could set our PEEP here, then that would be optimal PEEP because we could hold the alveoli open to that point to where they're ready to receive volume. Okay? From here, we come up here. This is our point 3. This is our bird beak. I'm just going to put bird. This is our bird beak. Anytime you see bird beaking, you are over distending alveoli. Again, look, we've started coming up to now moving more lateral. So pressure is increasing without a lot of volume change, and you are over distending alveoli, and you are at risk for barotrauma, ventilator-induced lung injuries at this point. So you need to be aware of this. What's the appropriate action here? You need to ask yourself, is my tidal volume too big? Is my PEEP too high? What's going on? Why is my patient bird beaking? Okay? On your board exams, the answer is going to be turn down tidal volume. They're going to give you some crazy random question that says you're on a tidal volume of 850 and you get this on your pressure volume loop. What are you going to do? Well, the answer is turn down tidal volume, right? Because you're bird beaking, you're over distending, your tidal volume is too big. Now, when we come back from here, we got this 4th spot right here, and this is critical closing point or critical closing pressure. This is a point at which alveoli are starting to snap shut. This is where they're starting to close, and you get a big drop in your pressure as alveoli close. Now this makes sense that if optimal PEEP is here at critical opening pressure, we don't want alveoli closing. We don't want them to shut. And so at the point of critical closing pressure, we could set minimum PEEP and use that to determine a point to where we say, okay, we're not quite at optimal PEEP, but we don't want our alveoli snapping shut. And so we're going to set a minimum PEEP so that we don't have this effect where during all of this phase right here, you have alveoli snapping shut and becoming atelectatic. So we want to keep those alveoli open. So that's what critical closing pressure is there. Okay? So those are the first 4 points. Now when you look at this, you can make this real simple. You understand that we have 2 animal parts. We have a fishtail and a bird beak. You know what those tell you. Increased work of breathing, or not enough sensitive, or not sensitive enough, failure to trigger, or over distension. We also have 2 critical points: critical opening, critical closing. Critical opening will point us to optimal PEEP. Critical closing will point us to minimum PEEP. Okay? And then there's 2 things left on this waveform that you need to be able to identify, and that is this. If this is normal, that's actually not normal. Hold on. If that's normal, then we need to understand if this loop goes down, such as this, then we have a decrease in static compliance, and this is static. If it increases, if it looks like this, then we have an increase in static compliance. Okay? Now, what would cause it to decrease? Just about anything, right? Pleural effusion, pneumothorax, pneumonia, atelectasis, ARDS, pulmonary edema. All of those things will cause this loop to go down, and it's a graphical illustration of a decrease in compliance. What would cause it to go up? Well, this would look more like an emphysematic patient. Their lungs are big and floppy and have very little resistance to volume because of the destruction of the distal airways and alveoli. So they have an increase in compliance, which allows them to stand up. The more common approach to this is understanding that when a patient comes in looking like this, as they get better, they will move up to this, and that's a sign of an increasing compliance, and that's a good thing, okay? The last thing, sorry I have to erase this so much, but if you want a good illustration, I got to do it like this. If this is normal, then if you see something like this, and you see this increase in the width, then you're looking at an increase in your airway resistance. So don't be shocked if your asthmatic comes in with a very wide loop, a very wide pressure volume loop. That's the result, a direct result of an increase in airway resistance, which is going to affect your dynamic compliance. Okay? For this patient, you need to figure out why they have an increase in airway resistance. Now let me show you something cool about this. If, I'm going to put all this together. If you have a patient that comes in status asthmaticus and you have a very wide pressure volume loop, right? Now we know that status asthmaticus comes in. This tells us we have an increase in raw. Okay? Well, what do we know about status asthmaticus? We know that because of the bronchospasm, they're going to air trap because they are unable to fully exhale all of their volume. We also know that they have an obstructive lung disease. So when we look at our flow volume loop, it would look something like this. We would see a scoop in our loop, right? This supports an obstruction, which we know, due to this increased airway resistance from our bronchospasm, is the cause of this obstruction. When we look at our pressure waveform, we will probably see something like this. This is PIP, this is PLAT, And this big difference between the two is our raw. So don't be shocked when you do an inspiratory hold and you get this big drop in your plateau pressure. Remember, formula for raw, pip minus plat divided by flow in liters per second. And so that, don't be shocked if you see that. And then because of the asthmatic and because of the airway obstruction, you might see something like this on your flow waveform. Not returning to baseline. Why? Because the increase in airway resistance, the obstruction on the flow volume loop, increase in raw supported by the pressure waveform is all leading to this patient air trapping because of the bronchospasm. And that's how all these tie together. You got to understand that most of the time when you have one finding on one, you will also find another abnormal finding on another. The pressure volume and the flow volume are nothing more than the pressure waveform, the flow waveform, and the volume waveform being put together on an XY axis. That's all they are. So anything you see on your pressure, flow, and volume waveforms, you're going to see on your pressure volume loop and your flow volume loop. Hey guys, this went longer than I wanted it to. I hope everybody's still with me. I hope this makes sense. Todd, if it doesn't, throw me a question up. I'd love to address it for you. If you haven't, again, already subscribed, please do so. I'd love to hear from you. I'd love to hear the comments that you think about this video. So, best wishes, guys.